دكتور عمرو.
تمام، شكرا دكتور احمد. نقدر ان احنا نكلوز السيشن دي ونبدا السيشن اللي بعدها عشان احنا متاخرين حوالي 10 دقائق.
بس دكتور عمرو ما كناش على اثناء نقل المؤتمر لما اتكلمنا عن اللي حصل امبارح مع شركه امجن.
ايوه،
فانا بكرر واقول ان احنا بنعتذر على اللي حصل وكان بره ايدينا، لان كان الخواجه المفروض يتكلم في وقت معين، وللاسف ما حدش وقف السبيكرز على الوقت المناسب، فحصل اوفر، وللاسف حصل ان على الخواجه طوالي، فكان لازم نقدمه. فاحنا اسفين جدا على اللي حصل لشركه امجن، ونرجو ان احنا يكون في تعاون منا بعد كده، وناسف على حصول هذه المره. شكرا جزيلا. الجلسه الثانيه بقى دكتور عمرو.
الجلسه الثانيه يعني may I call the chairpersons دكتور محمود عثمان، دكتور محمد القصاص، دكتور علاء السيد، دكتور محمد شرف الدين لافتتاح الجلسة القادمة من فضلكم. اللي موجود منهم، لو محدش موجود يبقى let me to introduce Professor Dr. أسامة عبادة. He will give a presentation about diagnostic algorithm in UC.
معاك يا فندم، مع حضرتك. انا محمد القصاص موجود يا فندم معاك.
دكتور محمد، شرف لنا وجودك. اتفضل حضرتك افتتح الجلسه وقدم السبيكرز. اتفضل.
اتفضل يا بيه. خلاص تمام. دكتور اسامه بيه اتفضل.
اتفضل حضرتك اتفضل.
بسم الله الرحمن الرحيم. يعني مبدئيا انا بسعد بوجودي مع حضراتكم النهارده. الحقيقه الايفنت عظيم جدا ما شاء الله، ومجهود كبير من كل الناس ومن حضراتكم، وبسعد بوجودي في الجلسه النهارده مع زمايلي ومع اساتذتي. ويمكن بدايه او اول محاضره في الجلسه هتبقى لواحد من الناس يعني بصراحه اللي كلنا بنعتبرهم من اللاند ماركس في الاي بي دي، استاذ دكتور اسامه عباده، استاذ امراض الجهاز الهضمي بطب اسكندريه. والبرزنتيشن بتاعته هتبقى على الدياجنوستيك الجوريزم ان السيراتيف كولايتس. دكتور اسامه بيتفضل.
بسم الله الرحمن الرحيم. انا بشكر طبعا الدكتور محمد على التقدمه، ونعتز بوجودكم جميعا معانا في المؤتمر الثالث لجمعيه الاي اس اي بي دي. وهنتكلم we'll talk about today the management algorithm in ulcerative colitis. The goals of management in ulcerative colitis usually include the extent of the disease, and this is required endoscopy of course, and pathology that shows chronicity. And what we need to know and to emphasize on the activity as well as the severity, because both of them will force us to do what kind of management we are going to do. The induction of response is our aim of treatment, to go for remission and then for maintenance. Try to avoid steroids. If we can use topical, that's fine. And try to treat any comorbid anxiety or depressive disorders, and to prevent complications in the form of carcinoma, hospitalization, infections, and others. The treat our target usually have been moved from steroid-free remission, avoiding of hospitalization, to more deep than that. Fecal calprotectin will help us to lessen the need for endoscopy. If it is not feasible, fecal calprotectin can help us to assess mucosal healing and disease activity. Now, histologic healing is start to be a distinct mucosal healing target and called histologic remission. So actually, the target of our treatment have been moved from just clinical steroid-free remission to biologic remission by the calprotectin and CRP, which are normal, to the endoscopic healing, which is in here in ulcerative colitis is Mayo score 0 or 1, to histologic here in ulcerative colitis, Ijibus score, Nancy score, and Robert's histology index RHI. Now Nancy score start to be, as we heard yesterday from Professor Perolé, that Nancy score is getting the acceptance more and more to be our target. The treat to target has been our policy in management. Second, thanks to the CALM trial, which proved that superior treat to target more better than treat to clinical management. And this cartoon will show us that our target has been moved in a tried consensus from clinically to try to resolve the rectal bleeding and monitor the patient every 3 months to that find that normalization and actually better. So our target had been better scores, PRO scores for patients, and validated now UCS score and my score for endoscopic targets, and starting the use of histologic targets, and also the use of adjunct fecal cut protectant cut value to demonstrate specificity and sensitivity and reliability, and now start the home-based test development in this. We need to review the definition before going to what we are going to do in those patients. We need to know that there is proctitis, left-sided colitis, and extensive colitis. And also we have the Mayo score system that shows that we have remission if you have 0 to 2, mild from 3 to 6, moderate 6 to 9, and severe 9 to 12. And then we can assess whether the location, and then activity and severity. For years, True and Love and Wits was the standard use of measurement of the activity, mild, moderate, and severe, and using this parameter till last year that the ECG has introduced the new UC activity index. They put, in addition, the urgency, as well as they add the CRP, the fecal cut protectant, the endoscopic Mayo score, subscore, and UCIS. And this picture shows the US and Mayo score 0, 1, 2, 3, and the UCS from 0 to 8. And for those, we can now know whether the patient have mild or moderate or severe. The parameters, as we said, the clinical remission is not related to the dermatological course, and what is related is either inflammatory remission, which CRP and cut protectant, and structural parameters, the endoscopy and MRI, and the histology. Fecal cut protectant and CRP can be able to detect the relapse before it happens in 6 months, and this is the story study, and also can said that we can assess what patient we are going to stop the biologic in the story study, that CRP and as well as cal protectant with these endoscopic score showed that the patient could go to deep remission. Also, recently, fecal cut protectant also can predict the endoscopic response to therapy with whether vedolizumab or ustekinumab. And as you said, it responded better. That patient responded cut protectant at week 8 means that the patient would have an endoscopic response at week 16. And the fecal cut protectant decreased as early as week 2 in responders in both vedo as well as ustekinumab. So what treatment we have? We have the standard 5-ASA, steroids, cyclosporine, anti-TNF, anti-integrins, anti-IL-12-23, and JAK inhibitors, as well as with microbial manipulation, as well as surgery. This is the option. We have medical steroids, cyclosporine, methotrexate, and those. And we need first to optimize our treatment. Try to combine anti-TNF with immunosuppressive if possible, anti-TNF with antibiotics in Crohn's disease perianal. We start the use of proactive therapeutic drug monitoring, which is after post-loading, immediately in the high-risk patients. You can measure the infliximab level, trap level, or adalimumab at week 4. In pediatrics, the pivotal study showed beneficial effect. Also, you can measure the 6-5-guanine metabolites, as we will see in a second. This optimizes the response in patient TFT for the Western and in UD T15 in the Eastern population. They have abnormal sensitivity to thiopurine, but by measuring the thiopurine and 6-mercaptopurine, we can say whether it is detectable, and we can enforce that the patient increase the dose or is not taking the drug. Or if it is low, then you can discuss adherence, increase the dose. If it is here high, it means that the patient will go for side effects. Also, to optimize, we need to understand that our first therapy will work better, especially Vido, Secukinumab, or Tofacitinib, better if you use it before anti-TNF and not after. And what biologic will first, TNF or lymphocytes or Secukinumab or JAK, then it depends if the patient severe and impatient, we need to go for infliximab or cyclosporin, better than Vido. Travelers use the subcutaneous secukinumab or adalimumab. Age above 65, I will avoid anti-TNF, vidozumab and secukinumab. Immunosuppressed, same. Lymphoma, same. If the patient has diffuse extracellular manifestation, anti-TNF will be better. If they have patient perianal infliximab, if psoriasis, secukinumab, low albumin cyclosporin, tacrolimus, and better than anti-TNF. And in ulcerative colitis, here the AGA, induction remission of the biology naive, they put infliximab first, followed by Vido, as well as the rest is secukinumab, not ranked because maybe the timing of the result of the guidelines and the effective also to but not in TNF naive in TNF non-naive. It's combined with immunosuppressive or not. AGA said combine TNF with thiopurine, especially if it is infliximab. But there is some evidence that Vido and secukinumab could be used mono because even anti-drug antibody less 4% in Vido and less than 3 in Secukinumab if they are used alone. So which biologic is better? There is no head-to-head except in ulcerative colitis, except in varsity, the vidozumab versus adalimumab, and Vido was superior to adalimumab by here is about 9 percentage points more better than this in clinical remission and histologic remission as well. We should remember that when escalating therapy, should when you already have your target, try to de-escalate, try to adhere to this, decrease the 5-SA. If there is a steroid induction, steroid sparing, and then try to have concomitant immunomodulator, then you can make it mono, especially if the patient was azathioprine naive patient. What diagnosis, how can we go for our treatment, whether the patient is severe or not, whether the high risk of colectomy or not. If the patient have high risk colectomy, you need to interfere rapidly. Great extent of disease, deep ulcer, high SRP, SR, low albumin. Also, if there is failure of 5-SA, a need for corticosteroids, first flare, and this is been proved in the momentum study. And this is the AGA clinical pathway said that if they have low risk of a patient, then oral, then or rectal 5-SA, then followed by oral budesonide or rectal steroids. If there is remission, maintain on oral or 5-SA rectal intermittently. But if the patient is high risk of colectomy, then we should have short course of steroids as initiation, and then start thiopurine, anti-TNF plus or minus immunosuppressive, Vido plus or minus immunosuppressive, secukinumab plus minus, and tofacitinib. If remission, we maintain. If no remission, then we try to switch, and we will see, talk in a minute. There is a recent publication just a couple of months ago about the position of therapy in ulcerative colitis. And they said if the patient is mild to moderate ulcerative colitis or distal, we said rectal mesalamine plus or minus oral mesalamine high dose. If responded, continue on oral and intermittent rectal. No response, then high dose in addition to rectal corticosteroid. If response, maintain. If not, we'll go for the moderate to severe. If the patient is left-sided, then we can add here that if the patient does respond, you can add budesonide MMX. Responded, that's fine, maintain. If no response, go for moderate to severe. And the moderate to severe, right away, corticosteroid plus oral, 5-SA. Responded, maintain on oral mesalamine. No response, then consider biologic. What about acute severe ulcerative colitis? Labs, stool studies, CT and X-ray, and supportive care of IVF fluids, electrolytes, deep vein thrombosis prophylaxis, and then flexible magnetic biopsy to rule out CMV and C. difficile. And if the patient will receive the IV steroids, in 3 days, improve, then go for oral. No response, surgery consultation, and then take the decision of collecting it or not. If the patient did not respond in 3 days, go for salvage therapy, infliximab or cyclosporin. Some may use JAK inhibitors as an induction. This is experimental, not approved yet. But if the patient responded, maintain. No response, that means it is refractory, and then we should consider the collector. And this is in the same study saying it's the same. What do if there is a partial response or no response? Is the bowel inflamed, or is there is infection, or is the drug not sufficient or not? If the patient is persistent, try to make sure that the patient is adherent. If the patient is adherent, then try to rule out, assess the infection, the inflammation, or rule out infection. And if so, try to treat infection cause. If not, then we'll go for mild, optimize the dose, mild, severe, then de-escalate your treatment. What about proctitis? There is called the refractory proctitis. Is the proctitis despite oral steroids and oral 5-SA. And the first possibility consider poor adherence or inadequate delivery of inflammatory mucosa, proximal constipation, CMV, or other venereal. Alternative diagnosis should be ruled out. And if so, then, as I said, whether the mild or moderate to severe, if you can assess the disease and remission, maintain. If not, then we can go for escalation or surgery we can use. Mild to moderate, the same. And as you said, we can introduce budesonide MMX in failing 5-SA. If the patient relapsing, using infliximab plus prednisone, if primary response, then you can consider to shift to cyclosporin or to fasotoniib. Or if it is a secondary loss of response, then optimize the dose by use what we will talk about in a second is dual biologic. And if respond, contain and maintain. If not, consider colorectal surgery, especially fulminant UC, toxomegavolum, systemic toxicity, or if the patient decided to go for surgery. Try to have alternative if you have alternative, and we will talk about in the dual therapy in a second. What about if you use the cyclosporin level and loss of response, then you can consider surgery, or you can, if you already responded that this way, you can use that way infliximab and then wean whatsoever. What to do with partial non-response? Also, possibility is the switch therapy, and you can switch, especially if not in addition to loss of response. If the patient have induced anti-induced leukoid reaction, you then use non-anti-TNF. If they have the patient already on VEDO and they have joint pain, then anti-TNF or TOFA. If the patient have psoriasis, then ustekinumab or TOFA or VEDO. If the patient about cancer, stop, and after you use VEDO or ustekinumab. What about combination? There is talk about the biologic combination now, and this is papers showed 6 papers showing this different combination last year, and this is the Calgary experience of those patients failed more than 3 biologic or 4 biologic, and use dual, but you add on the already existing biologic, and most of the patients have combination well tolerated and no side effects. Also, calcineurin induction could be followed by vedolizumab, and they have a good response to save some more patients. There is also a case report of using VEDO plus tofacitinib in ulcerative colitis and spondyloarthritis. The future of IBD therapy now will be that we diagnose, assess severity, predict the disease course, and then selection of our therapy. This all available now. And if high risk, early combination, low risk, rapid step up approach, and then treat to target or tie control. But we will be in the future is that we have new predictive tool to our management to monitor our management. And thank you very much.
شكرا جزيلا دكتور أسامة بيه على المحاضرة الجميلة. تمام، في أي حد من الزملاء التشير بيرسونز معانا في الجلسة تاني؟ طيب خلاص، ننتقل للمحاضرة اللي بعد كده. أستاذ الدكتور هاني شهاب، أستاذ الأمراض المتوطنة والجهاز الهضمي بكلية طب قصر العيني. دكتور هاني هيكلمنا على الكرونز ديزيز دايجنوستيك الجوريزم. اتفضل دكتور هاني.
Good evening. Assalamu alaikum jami'an. Thank you very much for having me in this prestigious meeting. It's an honor for me to be amongst my professors and colleagues. I will focus on the purely diagnostic algorithm for Crohn's disease. Now, if we ask ourselves what is the definitive diagnostic test for Crohn's disease, the basic answer is there is no single test, and we know that. The problem is that we have so many options. We have imaging options, many endoscopic options, many laboratory tests. We have biopsies and different methods to handle them. Now, the good news is that you don't really need the combination of all tests together to reach a diagnosis. Perhaps you need a combination of one or two of these modalities. The bad news is that we have too many options. So we really have to organize how we're going to approach this patient so that we don't exhaust ourselves in the different modalities. So yes, the ECHO states clearly that there is no single gold standard for the diagnosis of Crohn's disease. So whenever we try to start an algorithm, you'll find it starting by this statement. You have a patient with suspected Crohn's disease. So let's start here. We have to first identify who is actually suspected to have Crohn's disease. If we put all the possible presentations, you'll find them endless. Any patient with abdominal pain, fever, weight loss, an abdominal mass, family history, even the extraintestinal manifestation like sacroiliitis or uveitis could be a presentation of Crohn's disease. So we really have to select some specific, what we call the alarm features that really push you into following the diagnosis of Crohn's disease. This was a very clever study by Danesi et al. When they compared patients with Crohn's disease with other patients who had either IBS or were healthy subjects. And through a statistical model, they found that there are several really important presentations that are strongly associated with the possibility of Crohn's disease, like the presence of a non-healing or a complex fistula, like presence of a first-degree relative, weight loss, fever, nocturnal diarrhea. They actually developed like a scoring system. If a patient has scores more than 7, that he's highly probably to have Crohn's disease. In real life, you don't really need to score each patient, but you have to just bear in mind if you have any of these presentations, then you should really pursue following the diagnosis of Crohn's disease. So how about laboratory investigations? Are any of them good enough to diagnose Crohn's disease? This was a lovely study about the utility of fecal calprotectin. You'll find here on the left that yes, calprotectin has a much better accuracy profile than CRP or white blood cells or albumin or ESR. Overall, at the cutoff of 50, we have a very good sensitivity of about 97% or the specificity of about only 74%. So you could argue using this that if you have a patient with a negative fecal calprotectin, then you can just comfortably exclude that he has Crohn's disease. But again, it's never that simple. When we focus on patients with small bowel Crohn's disease, calprotectin actually performs a little bit less impressively. In this nice study, systemic analysis, you found that the sensitivity in small bowel disease ranges between 60 to 89% with a lower specificity. Overall, it is 83% sensitive and 53% sensitive in small bowel disease. So you really cannot depend on it in excluding or diagnosing small bowel Crohn's. ASCA and ANCA, I won't go into those in detail. It has been concluded that they are not sensitive or specific enough, and the ECHO actually does not recommend them in the routine diagnosis of Crohn's disease. How about endoscopy? What if we just do an endoscopy and we see the ulcers? Is this good enough to diagnose Crohn's? Yes, ileocolonoscopy is the primary first-line procedure to do if you have a patient with suspected Crohn's disease. But is it enough? No, because first of all, in many cases, you cannot actually enter the ileum. We all know that. And in many cases, actually, in about 10% of cases of Crohn's disease, you have isolated proximal small intestinal Crohn's. So you cannot only depend on ileocolonoscopy in those. Another thing is that if I put these pictures for you, however your level of expertise, you will not be able to tell me 100% accurately which of those is TB and which of those is Crohn's disease. For example, these upper images are all TB and the lower ones are Crohn's. How about those? I will leave for you a few seconds. Which one of these images in the terminal ileum say that this patient has Crohn's disease? Actually, none of them. All these were patients with Behçet's disease in the terminal ileum. So you just cannot simply depend on seeing ulcers in a patient and just say that he has Crohn's disease. So simply after that, you say, okay, then we'll do a histopathology. But it's not as simple as in cases of cancer, where you diagnose cancer with a biopsy, it's either yes or no. When we compared here patients with Crohn's disease with patients who had similar disease, for example, like lymphocytic colitis and so on, you think, of course, if we find a granuloma, then we've diagnosed Crohn's disease. No, the sensitivity is very low. It's about 24%, and specificity is only about maybe 25%. You notice that this has a very high specificity. It's actually not 100% in the larger studies, but even so, the sensitivity is very, very low, which is the pyloric metaplasia, only seen in 15% of cases. So again, histopathology alone cannot suffice to diagnose or exclude Crohn's disease. How about using a capsule? So the capsule will help us to see the small bowel and see more than what we can see with the colon. So this was a very clever study when they did capsule endoscopy and an ileocolonoscopy in the same patient. And the gold standard they compared against was the final diagnosis after 6 months. Now, the results were that ileocolonoscopy was actually much more sensitive than the capsule, but the capsule was more specific, and the capsule, of course, helped in the more proximal lesions. The other problem with the capsule is the capsule retention. This is a very recent meta-analysis in 2020. It showed the retention rate of 2.3 or 4.6%. There is this idea of using the patency capsule, which is a dissolvable capsule that you test in a patient before doing a capsule endoscopy. However, even with those, yes, the rate has diminished from 4.6% to 2.8% or 3%, but still 3% is a lot. This means that out of every 30 patients you do a capsule endoscopy, one of them will have a retained capsule, which is a problem. So you think, okay, then we'll go to cross-sectional imaging. Cross-sectional imaging had the advantage of seeing the depth that is not seen by endoscopy. It had the advantage of seeing the activity by Doppler. It had a possibility of seeing the fistulas, so ultrasound, MRI, and CT. Which one of those performs better? Several studies and meta-analyses have basically concluded there is no strong preference of one over another. Everyone has, each one of them has its advantages and disadvantages. Mainly the advantage of MRE is that it has a very good soft tissue resolution. There is no radiation, and there's the problem of artifact with the motion of the bowel. CT is rapid. It very accurately depicts collections if you have suspect abscesses. The major disadvantage is the radiation. Ultrasound, it had the advantage of being real-time assessing, so you can see the peristalsis and movement. There is no radiation. It is less costly. However, it is time-consuming, and it is really highly dependent on the operator experience. So I'm blessed of having a very experienced bowel ultrasonographer that makes us really depend on her and everything, but it depends on where you work, actually. So the Crohn's actually states that whatever you find in ileocolonoscopy, whether you diagnose the patient or not, you still need to do assess the small bowel. It does favor the use of cross-sectional imaging, whether MRI, CT, or ultrasound, but they stress on the point of the avoiding radiation exposure. So we're all leaning now towards MRI and ultrasound and tending to go away from CT due to the risk of radiation. When we think about the small bowel, we say, okay, then why not just use the capsule, or should we use the MRI or the ultrasound? Now, when they compared those in assessing the small bowel, in the distal small bowel, they were actually more or less similar. So the capsule versus MRI was similar, capsule versus ultrasound was also similar. However, when you look closely only on the proximal small bowel, you will find that the capsule actually is slightly better than the MRI and is slightly better than the ultrasound in detecting small bowel Crohn's. However, capsule specificity is a bit low. We have to remember that about 10% of individuals do have mucosal, of normal individuals have mucosal breaks and erosions in the capsule. There is the significant risk of retention, and there is the problem of the cost. So at the end of the day, the ECHO still says that small bowel capsule endoscopy should be only used in patients where you still cannot reach a diagnosis confidently after excluding the colonoscopy and the imaging techniques. So now we're down to an algorithm. This is one of the simpler ones that I found, and I like it. So basically, if you really don't much suspect Crohn's, a fecal calprotectin is enough to exclude Crohn's. If it is highly probable, then you should proceed with ileocolonoscopy. If you're still uncertain, proceed with cross-sectional imaging. Still uncertain, then go to capsule endoscopy. And at any point, once you're certain of the diagnosis, you still have to do cross-sectional imaging to confirm the diagnosis. Now, I'm sorry to disappoint you that it's still not the end of my presentation. because these algorithms, this one and similar ones, they were based on the Western guidelines, on prevalence of Western disease only. If you look at the Asia Pacific consensus, which when these are countries with perhaps more similar demographics to ours and more similar prevalence of disease to ours, you'll find them stressing on testing for Mycobacterium tuberculosis. This is something that we should never forget in Egypt. Perhaps we don't have a very high prevalence such as India, but still, I believe all of you agree that we still do see sometimes intestinal TB. All right, so will we just depend on the clinical and endoscopic features of TB to differentiate with Crohn's? Unfortunately, the sensitivity of these features are very low. The specificity are high, but they are still not 100%. For example, hematochezia and history of surgery and perianal disease in Crohn's. In TB, presence of ascites or a fixed open ileocecal valve. They are nice, but they're not strictly accurate in differentiating. If you look at all the tests that we have, I think only the acid-fast bus staining and the culture approach 100% specificity, but the sensitivity, as we know, is very low, in the 20% averages. The gene expert test is perhaps one of the most promising tests, but still the sensitivity is not 100%. So again, you have to depend on a combination. And even sometimes after all those, you still are justified to do an anti-TB therapeutic trial. And I think this is something that we do less in Egypt, and I think we should do it more. So if you have diagnostic confusion still between Crohn's disease and TB, basically, if after 2 to 3 months you don't have a response, then you're probably having a case of Crohn's disease. If you do have clinical improvement, you should continue the trial for another 6 months and then assess endoscopically. If endoscopic improvement has been also confirmed, then this patient has TB. If there is still endoscopic activity, then no, then it could be still Crohn's or perhaps coinciding Crohn's and TB. So this is our algorithm that I think we should follow. You should always suspect TB and perhaps use a minimum of the PPD test and a quantiferon and chest X-ray in every patient. And in difficult cases, you should always consider the anti-TB therapeutic trial. So I will end with this slide. I've discovered recently that there is a type of art called anamorphic art, and I found that it is actually very similar to what we have been doing in Crohn's disease. So basically, this art depends on, they use these bits and pieces of very random things like pieces of furniture, cloth, and so on. And each one alone has no sense on itself. But if you put them correctly, very carefully, and with the correct perspective that you look at it, you reach a very clear and confident diagnosis of Crohn's disease. I leave you with this piece of art, and I thank you very much. Dr. Assas? I think Dr. Assas maybe has a problem. So
معاك دكتور هاني، مع حضرتك.
اتفضل.
تمام، شكرا جزيلا دكتور هاني. مش عارف الوقت يسمح ان احنا ناخد اسئله؟
للاسف لا يا دكتور أصاص.
خلاص تمام يا بيه. خلاص نشكر حضراتكم جزيلا وننتقل ان شاء الله للجلسه القادمه.
شكرا جزيلا دكتور أصاص.
شكرا.